Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, die Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie Dialyse Transplantation, Marcus at Home welcomes Dr. Stephan Burgess in Cambridge, UK, in order to discuss whether or not a low vitamin D status should be considered from an epidemiological standpoint as a driver of coronary heart disease, stroke, and all-cause mortality, focusing upon his recent seminal observational and Mendelian randomization analyses published in Lancet Diabetes Endocrinology earlier this year. Dear Steve, it's a pleasure to host you.
Thank you so much. Thank you for the invitation.
Stephen, thank you also from my side. And let me just give our audience a brief introduction. Dr. Burgess is a medical statistician at the University of Cambridge, and whose main area of research is causal inference and specifically methods for so-called Mendelian randomizations. I'm sure we will talk about methodology as well as your trial. And the topic today is vitamin D and supplementation of vitamin D, which is a kind of a relevant issue for patients and even more for general population, driven by a huge amount of publications in lay press and even in scientific organs, because vitamin D is set to cover a kind of broad range of relevant topics, starting with kind of well-being, longevity, maybe lower cardiovascular mortality, but there's some controversy on that. And so we're really happy, Stephen, that you introduced us to your latest trial published in the Lancet and give us some glimpse and some insights tonight. So we're very interested and excited to see your slides.
Thank you. Thank you for inviting me. I do feel like something of an outsider, but hopefully I can introduce you to the world of genetic epidemiology and statistics. So I'm going to start off by giving a brief introduction. What is this idea of Mendelian randomization? And then talk a little bit more specifically about vitamin D. So the problem that we're dealing with is one of observational data. So we want to learn about causal relationships. But I'm sure most listeners will know correlation is not causation, that a factor and a disease can be correlated with each other without there being a cause of that risk factor on the disease. So if we take, for example, red wine, we observe observationally people who drink more red wine have better cardiovascular health. There could be a causal relationship there. It could be genuinely if you changed somebody's red wine consumption but didn't change any other factors, that would reduce the risk of coronary heart disease. But there could be other explanations. These observational associations could occur because of confounding. So common risk factors, so for example, socioeconomic status or better physical activity. Or it could be reverse causation. It could be that you go to the doctor tells you you've got some preclinical signs of disease, you should cut down on your red wine consumption. And so again, there's a relationship that we see between them, but it's not red wine driving coronary heart disease. So the ideal way to solve this problem is through a randomized trial. So in a simple randomized trial, we could maybe have a treatment group and a control group. We randomly assign people to one of those groups. And that helps us with the problem of confounding. It means that the groups that we're going to be comparing are going to be equal as regards to all of these potential confounding factors. So that helps us to deal with the problem of both factors that we can measure, factors that we can't measure, factors that we don't even know about. Also, by running a randomized trial, that gives us a time ordering. We do the randomization and then we see the outcome. So that helps us with the problem of reverse causation. So if we want to learn about the effect of red wine on coronary heart disease, we can just set up a randomized trial. We can recruit patients at age 20. We can say, come along, please join our trial. The trial takes 50 years. We will flip a coin now. If the coin comes down as heads, you will drink red wine for the next 50 years. If the coin comes down as tails, you will not drink any red wine for the next 50 years. Please do adhere to your treatment and we'll see you in 50 years' time. Obviously, there are some difficulties in running such a trial, both practically and ethically. So we need other approaches to address questions about cause and effect other than randomized trials. And this is where this idea of a natural experiment comes in. So an instrumental variable is a variable which gives us something which is similar to a trial, but we ourselves are not doing the randomization. We're allowing nature to do the randomization for us. So in particular, an instrumental variable is a variable which affects the risk factor of interest. It changes its distribution in the population, but it's not associated with any potentially confounding variable. And the only way that it can influence the outcome is via the risk factor. So if you're familiar with causal diagrams, you might be able to recognize this figure on the right. Even if you've never seen it before, though, it should be clear the flow of causation in this diagram, that X here is the risk factor, the Y is the outcome. So we have a putative causal pathway from the risk factor to the outcome. We have these confounders, these common causes of the risk factor and outcome. And the instrumental variable is this Z here. It influences the risk factor of interest, but it has no relationship with the confounder, and there's no direct effect on the outcome of interest. And hopefully in a well-controlled, well-designed randomized trial, randomization plays the role of an instrumental variable. But taking natural experiments further, anything which kicks the system, which comes from outside the system, but influences the risk factor in sort of an external, technical term would be exogenous way, can form an instrumental variable. So this provides us with a natural experiment. So similarly to in a randomized controlled trial, where we might have a control group and a treatment group, we can look at this randomization by our genetic variant, which divides the population into groups defined by whether they have a particular genetic variant or whether they don't have a particular genetic variant. And if we choose this genetic variant in a clever way, such that it associates with the risk factor of interest, we divide the population into these groups, which are just defined according to their genetics. They have different average levels of the exposure, and hopefully they have no different levels of all the confounders, such that if you see an association between having this genetic variant and the outcome, that's indicative of a causal effect of the risk factor on the outcome, similar to an intention to treat analysis in a randomized trial, where you look for an association between randomization and the outcome. But why genetic variants? Well, we often know what genetic variants do. We know that they're located within genes. We know what the genes do, so we can choose variants in genes which relate specifically to the risk factor of interest. We can look empirically, and we'll show some data in a moment, that certain genetic variants seem to be quite specific in terms of their associations with traits. And then finally, the genetic sequence is determined at conception. And this helps us with problems of confounding, that environmental confounders can't change whether you have a genetic variant or don't. And it also helps us with the problem of reverse causation. The gene can never be the effect, it can only be the cause. So in terms of what is Mendelian randomization, it's the use of genetic variants as instrumental variables to make causal judgments from observational data. So thinking about vitamin D, and here we're using 25-hydroxyvitamin D, which is the circulating form of vitamin D as the exposure in the study. For the analyses that we're going to look at, we're going to consider 4 gene regions which have clear biological links to vitamin D, either synthesis, metabolism. So we're going to look at variants in the GC gene region, in this DHCR7 gene region, this CYP2R1, and this CYP24A1. All of these gene regions, their function relates somehow to vitamin D biology. And so we might expect that the genetic variants in these gene regions might affect levels of 25-hydroxyvitamin D in quite a specific way. We're going to construct what we call a genetic score, which comprises of variants in these gene regions. The idea is if you have low values of the score, that predicts low values of vitamin D. If you have high values of this genetic score, that predisposes you to having, on average, higher levels of vitamin D. We're also going to compare this to what we might call a genome-wide score. So not looking at the function of the genetic variants, just saying we run this genome-wide association study, we find genetic variants which associate with 25-hydroxyvitamin D. So here we look at the genetic associations with various traits. So in a simple way of looking at it, we've divided the population into different groups. And the first question is, do these groups have different levels of 25-OHD? And the answer is yes, we see a very strong association here with 25-OHD. But there's no clear association with any of these other risk factors, whether it's body mass index or blood pressure or lipids. The groups that we're dividing into, or the groups which nature is dividing the population into for us, have different average levels of 25-OHD, but have similar average levels of body mass index and so on, such that when we make this comparison, if we just do the standard epidemiology, then the group with the higher levels of 25-OHD would also tend to have lower levels of body mass index, lower levels of blood pressure and so on. They'd generally be healthier. But here we're able to compare these groups which only differ with respect to the levels of 25-OHD. So I can't prove this. I haven't looked at all different risk factors here, and maybe there is a slight association with HDL cholesterol here. This confidence interval doesn't quite cover the null. So maybe there is a little bit of uncertainty here. Obviously, if we look at enough traits and we just draw 95% confidence intervals, we'd expect 5% of the traits, but those confidence intervals would not include the null just by chance alone. But if we compare this to this genome-wide score, we can see again this genome-wide score, we're dividing the population into groups which differ as regards to their levels of 25-OHD, but they also differ with regards to levels of LDL cholesterol and triglycerides. And it's these associations here which mean that we don't want to look at this genome-wide score. We just want to look at this genetic score that's been specifically chosen because of its functional relevance to vitamin D levels. Now, the first paper that I'm going to bring up is slightly old papers, this from 2015. So this is looking at vitamin D and multiple sclerosis risk. Look here at 4 different genetic variants corresponding to these same 4 gene regions. The estimates are slightly odd here. They're scaled per decrease in natural log transform 25-OHD. So for each of these genetic variants, we're saying if you have the variant copy of these mutations, here we've got the SNP numbers here, we're saying that this predisposes you on average to having lower levels of vitamin D. What are the associations with multiple sclerosis? Well, these are all in the positive direction. So for each 4 of these variants, these are all uncorrelated, they're independent, they're in different gene regions, they act via different pathways. But for each one of these variants, the group in the population with a higher level of vitamin D has lower risk of multiple sclerosis. So again, there's untestable assumptions here. Are these really instrumental variables? But all 4 of these pieces of evidence, all 4 of these comparisons are pointing in the direction of vitamin D being protective for multiple sclerosis risk. In other words, the genetic variant which predisposes you to higher levels of vitamin D, people in that subgroup of the population have lower risk of multiple sclerosis. So the first thing that we looked at in terms of our analysis was looking at mortality. So again, do people with genetic predictors of higher 25-hydroxy-D have greater risk of mortality? Or equivalently, do people with higher genetically predicted levels of 25-OHD have higher risk of mortality? And the overall answer was no, that there was no association between genetically predicted 25-OHD and either coronary heart disease, stroke, or all-cause mortality. And each of these estimates is scaled to a 10 nanomole per litre change, increase in 25-OHD. So this is similar to what could be achievable through low dose supplementation. And we're really not seeing in the population average in these overall analyses any association with any of these diseases. But the question which we really were interested in was, what if there's a non-linear relationship between 25-OHD and disease? And such a relationship might not be picked up even by randomized trials. Quite a lot of randomized trials tend to focus on recruitment of the general population, and that often means healthier than average individuals. Often people who are recruited into a trial, they might take vitamin D supplementation even outside of the trial. So maybe some people in the control group are receiving a low dose of vitamin D. So I think this is a question which trials can answer, but maybe not perfectly. And the question we wanted to ask is, can the genetics give us an insight into this? So if we think about a trial or we think about a genetic change, so I've put here, this is from a graph where we were looking at alcohol, but this could equally as well say 25-OHD levels if we change the axis scale slightly. But whether you run a randomized trial and we're looking at supplementation or whether we're looking at alcohol reduction, we're not looking at just shifting from low levels to high levels. We're looking at a distribution of risk. And we're saying that the randomization would change that distribution. In the case of 25-OHD, we would be looking at increasing that distribution. So when we look at what would a randomized trial be telling us, it's telling us what's the effect of a shift in the distribution. So it would be the average effect across those people. So the question we asked was, could we divide this in some clever way such that we weren't just comparing the whole distribution, maybe the whole red distribution as those who don't take supplements or those who have a genetic variant predisposing them to low levels of vitamin D, versus the blue distribution, which is the people who have a genetic variant predisposing them to higher levels of 25-OHD, or equivalently in a real trial would be taking that supplementation. So could we somehow stratify the population? And I'm not going to go into the details of the maths, but the answer is, depending on what assumptions you make, you can look at different comparisons. You can divide the population and make comparisons in different ways. And the first method that we used to do this was something which we call residual stratification. And this gave us quite a striking result. You can see here, particularly for all-cause mortality in the deficient subgroup, we got this estimate very much in the protective direction that 25-OHD was reducing risk of all-cause mortality. And this was a result which we initially published in 2021. But looking at this more closely, there were some concerns that if you look at the overall estimate here and these estimates in all of the strata, that the strata estimate really are just to one side of the overall estimate. So following this, we developed a second statistical method, which we call the doubly ranked method. And this gave quite different results. We can see here for all-cause mortality, as well as for different coronary heart disease, for stroke, for cardiovascular mortality. We can see now all of the estimates line up with the null. So we spent some time here and we tried to understand which of these methods is more reliable, and so which of these answers is more reliable. And it turned out that actually the second method seemed to be more reliable. So actually we went back to the journal with these findings, and to cut a long story short, this initial paper was retracted. We ended up retracting and republishing this paper, and republishing the paper using the new results, which suggested a null relationship. So in terms of nonlinear Mendelian randomization, I think Mendelian randomization is already a controversial method. I think any method which makes causal claims is always going to be somewhat controversial because it must rely on untestable assumptions. We always need to claim that we're comparing groups of the population which are comparable, differ only with respect to the risk factor of interest. And that's always going to be controversial. I think sometimes Mendelian randomization analyses are quite plausible and they can give us reliable insights, but in other cases, they're not more plausible. Nonlinear Mendelian randomization makes stronger assumptions than standard Mendelian randomization. We need to make assumptions which allow us to look at strata of the population. In my personal view, the most plausible nonlinear Mendelian randomization analyses, in particular using this updated doubly ranked method, are more plausible than the least plausible standard MR investigations. There's a spectrum as to how much do we trust the assumptions that are made, and I think that nonlinear MR is always going to be further along that spectrum in terms of being making stronger assumptions, so being more vulnerable to those assumptions being violated. But I still think it can give us valuable insights. Others, however, disagree, and there was a publication recently, or an editorial by George Davey-Smith, saying that nonlinear Mendelian randomization publications, and in particular these are the ones using the original method, report spurious results and require major correction. So this was in response to another paper which also used this first method, and this paper is now under a note of concern. However, having said that, we had null results for using the updated method. We've actually re-performed the updated method on some different outcomes, and in particular, lifetime major depression. There was some hint of a protective effect in the lowest stratum using this method. So it seems as if even this new method does seem to reveal perhaps some effects of vitamin D supplementation. And there are some clinical trials which do suggest that depression risk could be reduced by vitamin D supplementation. So to come to the end, so Mendelian randomization is a potentially powerful but fallible technique. It requires a lot of insight. It requires expertise from a lot of different domains in order to be performed in a way which is accurate. It needs us to understand the genetics, what the genetics do in terms of biology, what sort of clinical outcomes we need to look at, the statistical methods, how these relate to people. And even when we think we're doing it carefully, as we saw from our initial vitamin D supplementation publication, that this can be done making errors, and hopefully we have now corrected that in the literature. Mendelian randomization studies for vitamin D, which look overall, have generally indicated null results for most diseases, with the exception of multiple sclerosis. Initial nonlinear MR investigations using the less reliable method, the residual method, suggested strong effects in low vitamin D individuals. But these updated methods using the more recent, I'd say more reliable method, have given largely null results, although with the potential exception of depression. So thanks for listening. Lots of people to thank who were involved in this work. Let me put a quick advert. If you want to learn more about this, we run courses both on Mendelian randomization and Mendelian randomization for drug development, and some references. In particular, the first reference gives some details into what is Mendelian randomization, and then the other papers that we discussed during this presentation. So thank you for listening, and really happy to open the floor to discussion.
Thank you so much, Stephen, from my part. For a clinician, this is, as you know, this is tough to understand, to be very honest with you. And I've had that back in my experimental time also when I work with biostatisticians who are incredibly intelligent people. And I do have difficulties understanding everything, to be honest. And I think the same holds true for some of our listeners, although you very, very well explained everything. Thank you so much. But at the end of the day, I think we'll have to come to Cambridge in November to really understand it. I know you're a statistician, but trying to take or build the bridge towards biology, even if that's not your area really, would you say from a scientific standpoint, science is what you can calculate with MR, and the biology isn't so important? Or would you say, okay, if I have a result that's biologically implausible, that makes a difference to the way I look at the data? Or would you try and stay away from that? I have the impression that one tries and be very pure and not go for, well, this is what I believe and this is what I don't believe. We all, in daily clinical practice, this is what does affect us.
Yeah. No, this is a really good question. I mean, obviously, we want to go beyond just saying, we've performed these analyses, we trust the results, therefore we believe the methods. We want to be able to say, well, we really want to address controversial questions where we really don't know what the answers are going to be. But equally, in some cases, I think it is good to be guided by what we know in terms of clinical trials, for example. So, for example, the multiple sclerosis story is not just evidenced by Mendelian randomization, it's evidenced by studies of migrants, it's evidenced by looking at latitude and the relationship between latitude and risk of multiple sclerosis. So I think where we have cases where we have some confidence of the answer, that can help us in terms of validating the methods. But equally, we want to give some room for the methods to give us answers which we weren't expecting and which we then have to try to understand in the light of those analyses.
Talking about latitude, how much of it's a UK Biobank data, isn't it? So
we used most of the UK Biobank data in these analyses, particularly the newer analyses. Yeah. So
does that have any effect on the generalizability of the data to the whole, world, northern, southern hemisphere, countries with more sun, more vitamin D exposure potentially? Is that totally generalizable?
Yeah, so absolutely. So in terms of the range of vitamin D levels or 25-OHD levels that we were able to look at, we're using UK residents. We actually restricted our analysis to individuals of European ancestries. And it's something which we know is not ideal from a representative perspective, but we want to make sure that any genetic associations that we look at don't just represent sociological, social, ethnic ancestry differences. We want to make sure that the genetic associations really do have a biological interpretation. So, for example, we're not able to look at dark-skinned individuals who have lower levels of 25-OHD. And yeah, the analyses were specifically conducted in UK-based populations. So, for example, where we draw those lines when we're looking at quintiles of the population, how many people are in that lower quintile really are vitamin D deficient. That might look different if we were looking at data from a different country.
Well, I have another question. Why would in the beginning you told us that the genome-wide association did not do such a great job, and you abandoned that in the end and went for the 4 genes that you focused on? I might have missed that, but could you try and explain why that was the case? Because from other parts, especially in cardiovascular medicine, we look at GWAS more and more, and there's analyses appearing. Professor Schunkert from München does a lot of work there that actually tells us that there is quite an association and a genetic trait that predicts at least coronary disease. Why did that not do a job in your analyses?
Yeah, that's a great question. So there's a lot that we can do with genetics and a lot that genetics can tell us. So we're specifically interested in what genetics can tell us about mechanisms. And so there's a trade-off between specificity versus, I guess, power or discriminative ability. That if you're just interested in identifying who is at high risk versus who is at low risk, then we'd want a very all-encompassing score, a score which includes genetic variants, no matter what the mechanism is. But here we're really using the score as a lever, really, as an instrument to help us understand about the effect of vitamin D. And so we want this score to be as clean an instrument as it can be. We want it to just represent mechanisms which relate to vitamin D synthesis or metabolism. So we sacrifice some of the predictive ability. So if we had a score which was more all-encompassing, then yes, we'd have a score which better predicted levels of 25-OHD. But that score would also involve mechanisms which don't specifically relate to 25-OHD. So it was in trying to get a more specific, a cleaner, less pleiotropic is often a word which we use. So pleiotropy meaning having multiple mechanisms. So that's really the motivation for looking at a more restricted score.
And if I may ask you, this effect that when you use the genome-wide score, you also have this dilution by cholesterol parameters. Does this result from the fact that the pathways of synthesis of vitamin D and cholesterol start with the same enzymes, so that this may explain this dilution?
Yes, I think that's a really good point. I wish I had a whiteboard to draw in front of me. So we really want the gene to go directly to the vitamin D, such that there's no pathway other than through the vitamin D. Whereas you might think that if there are some genes which affect cholesterol synthesis, and then they're going to affect 25-OHD as a secondary effect. So there could be these pathways from gene to cholesterol to the outcome, which we wouldn't pick up. So if that kind of cholesterol tampered score was associated with the outcome, it might be due to the effect of cholesterol, not due to the effect of 25-OHD.
May I ask also a technical question? You used 4 genetic constellations associated with vitamin D status. Maybe stupid question, but are those 4 all of them, or is there a chance to get some more? And the number of genetic constellations, the more the better? Does that predict the outcome, or just a technical thing? How do you think about that before you start?
Yeah, that's a great question. So yeah, if there were other biologically relevant genes, then we could look for genetic variants within those genes. I think really we want to ensure that our study has got enough power to be meaningful, but we don't want to, if we can avoid putting more genetic variants in, so making these assumptions about more variants, then that would be ideal. I have simplified slightly, so actually the score consists of 21 variants in these 4 gene regions. So for each of these gene regions, we select somewhere between 3 and 6 genetic variants, in that, you know, it might be that it's not just a single genetic mutation in that gene. It might be that we can predict 25-OHD levels better. So the scores is restricted to the 4 gene regions, but for each gene region, we try to model and we try to explain as much of the variability in 25-OHD as we can.
These data on multiple sclerosis, do they also have to be recalculated now with the new method? So do the same limitations that you found in your original analysis do also apply to these analysis on multiple sclerosis?
No, because they were looking at overall results. The new method is just for the non-linearity, just for trying to, I mean, we call it non-linearity, and in fact, it's more like a stratification. So the idea is that rather than looking at the population as a whole and comparing, I mean, like I said, you could do a similar thing in a trial where you compare cases versus controls, or treatment versus controls in a trial, where we might say, could we try to divide that trial population up? So yeah, so the multiple sclerosis is just looking at the overall population. And so that's...
But this is somewhat backed also by clinical data, because this large vital study, that to my best understanding, largest study ever done, randomizing people to receive or not receive vitamin D, which was completely neutral with regard to cardiovascular events and also to oncology, found, at least in a secondary analysis, some effects upon autoimmune disease. So there might be some effects here, even though cardiovascular events are not affected. Are you planning to do an additional analysis? So do you also have data on, say, bone health to look into bone events from the same database?
Bone events is one which I haven't looked at. We did some initial investigations. I think that somebody has looked at that previously. We have looked at different autoimmune diseases, and we did see some result for that. I'm trying to remember myself what we saw. We saw reduced risk of, I can't pronounce it, Schirmer's disease. That the genetic predictors of higher vitamin D were associated with lower risk of Schirmer's disease. For bone health, you'd think that vitamin D would be a positive, or bone health would be a kind of kind of positive control for vitamin D, but actually the relationship is not so certain, even from randomized trials, that vitamin D supplementation really increases bone mineral density, for example. I have to say I'm not up with all of the literature on that, but my recollection was that wasn't so clear even from trials.
Because we just saw new recommendations from the Endocrine Society a couple of weeks ago, which are somewhat difficult really to understand, which on the one hand side says, well, you do not have to measure vitamin D anymore in normal individuals. At the same time, they recommend to give low-dose vitamin D at least to elderly people for protection, and maybe the bone issue would be the one that might kind of explain this. They also recommend to do this for people with pre-diabetes. Two additional questions. So the people included into your study were largely from primary prevention, but there were some people who already had a cardiovascular event before.
Yes, so UK Biobank is it's a cross-section of the UK population. So individuals were recruited regardless of prior events. As with most medical trials, we tend to recruit more healthier and wealthier individuals. We took cardiovascular events even if they happened before study entry. The idea being that the randomization that we're exploiting is at before birth, is at conception. So that's really the baseline for our study. But we did also look at results just looking at events after study recruitment as a secondary analysis.
My last question would be, so you write in your paper that this genotyping explains about 5% of total plasma vitamin D, which to clinicians does not sound that much, but that's enough really to decide whether or not there's an effect, if I got it right.
Yes, that's certainly what we would say. So even if you looked at vitamin D supplementation in a trial, even in the VITAL trial, it's not as if supplementation in the trial explains 100% of vitamin D levels. So in the trial, it was about 25% of levels. So we're looking at, you could say we're looking at a trial where the intervention is about a fifth the size of that in the VITAL trial. So yes, it is going to be lower power for the same sample size, but equally we're able to look at a sample size of, in UK Biobank, about 350,000. So yes, there is some limitation. That limitation comes in terms of the confidence intervals for the estimate. If we had genetic variants which explained more of the variability, we'd be able to get a tighter estimate. But I'd say yes, we are. Essentially, we're looking at what's the effect of a lifelong kind of nudge towards higher levels of vitamin D. So maybe what we lose out in terms of not explaining quite the same magnitude of effect, maybe we gain a bit of that because we're looking at something which is not just across a trial. We're looking at something which is lifelong.
I have a question sort of going the same way. Talking about sub-analyses, you mentioned the 4 or the 21 traits you were putting into the investigation. Is there a possibility to do something like a sub-analysis now, saying, okay, this and that has a stronger effect, and this genetic predisposition, for example, to have a higher uptake via food or have whatever? Is that something that you can get out of the data, that you can tell us where the vitamin D actually comes from and where it has an effect or may not have an effect?
So I think probably unlikely in the analyses that we're looking at, because these genetic variants are they're not tissue specific, they're not organ specific. If we had genetic variants which corresponded to a specific intervention, then maybe we could say something about that specific intervention. So maybe let's take the example of LDL cholesterol, where we can look not just at a genetic score which predicts LDL cholesterol, we can also just look at variants in the HMGCR gene, which in a sense mimic statins, or in the PCSK9 gene, which mimic PCSK9 inhibitors, and so on. So really, I think we're limited as to what nature has given us and to how much we can interpret it.
So I have to add one question, because again, we arrive at understanding the background and also these analysis up to the point where it comes to this new method, to this doubly ranked stratification method. So if you would try to explain in very basic words to clinicians like us, so is there any chance for us to understand this method, or is it just too complicated for ordinary clinicians to understand?
I can try, and maybe if you leave this in the recording, then readers or listeners will know that I've succeeded. So the difficulty in a randomized trial would be between baseline covariates and post-randomization covariates. So we're allowed to stratify the population on baseline covariates, but we're not allowed to stratify on post-randomization covariates. So the difficulty comes in is that the randomization is at birth, but what we want to stratify on is a post-randomization covariate, if that makes sense. So coming back to the slide which I included in my talk, saying that we're looking at the shift of the distribution, something that you might want to look at, you might want to say, let's just draw a line. So we've got these two equivalent distributions which we want to compare, these two equivalent populations. What if we just say, thinking about units of alcohol rather than vitamin D, but what if we just said, let's stratify to say, let's just look at those who drink less than 2 units of alcohol per day. Well, you can see the red group and the blue group, they're no longer similar to each other. They're no longer, the shape looks very different. And this is to say this would no longer be a fair comparison. It wouldn't be they wouldn't be equivalent between these two groups. But if we assume that the effect of the genetic variant is to shift in a uniform way, then we could draw a line which is in a different place for these two groups. So if it's a half a unit shift, we could draw the line here at 2 units, and we could draw the line here at 2.5 units. And we could say not only are the red and the blue populations what we call exchangeable, they're similar to each other in total, but that this red group here is similar to this blue group here. And similarly, if we drew from 2 to 4 in this top group and 2.5 to 4.5, then again, we're looking at groups which in some way are similar to each other. So this was the idea of the initial method, that could we draw lines which are in slightly different places for these genetic groups. In a sense, what we're doing is that we're shifting this blue group slightly to the left. We're saying, what if this blue group who have the gene which predisposes them to drink more alcohol, what if they had been born without that gene? Well, then their distribution would just be shifted to the left, and then we stratify based on not where they are now, but where they would be if they had the 0 genotype rather than the 1 genotype. So this is the logic behind the residual method, the initial method, which we would now say has been somewhat discredited, particularly by these vitamin D analyses. So this is if you really want to know the maths, we go to residual, but let me push past this. So the idea of the doubly ranked method is to give some more flexibility in the modeling, to say that we're not just shifting the population in a uniform way to the side, but we're shifting the population in a more sensitive way. We're saying, again, suppose that we had 2 genetic groups, the 0 group and the 1 group. We're saying that suppose you were at the 10th percentile of the alcohol distribution in the 0 genetic group, that you'd also be in the 10th percentile of the population in the 1 group. And similarly, if you're at the 60th percentile, you'll still be at the 60th percentile. If you're at the 70th percentile, you'll still be at the 70th percentile. So suppose we have this hypothetical population of 1,000 people, and suppose that we have this particular genetic score, which takes these very specific values. Suppose we have exactly 10 individuals with the genetic score of 1, 10 individuals with a genetic score of 2, 10 individuals with a genetic score of 3, and so on. We could first divide the population into groups such that we have a group of these 10 individuals with Z equals 1, 10 with Z equals 2, and so on. If you're following me so far, we would then say amongst all of those with this genetic score of 1, let's take those with the lowest value of the exposure, and that would form our stratum 1. The second lowest value of the exposure, and so on. So what that might look like in terms of numbers, so we've got our 10 individuals with a Z equals 1, we've got our 10 with a Z equals 2, 10 with a Z equals 3, and so on. And then within these groups here, we take the individual with the lowest level of the exposure, the lowest level of the exposure, the lowest level of the exposure. So you can see that this red group, which we end up with, this contains exactly 1 individual with Z equals 1, 1 individual with Z equals 2, 1 individual with Z equals 3. So now we've constructed groups where the distribution of the genetic variant is exactly the same in these 10 eventual groups. So each of these groups contains exactly 1 individual with each value of the genetic variant. But these groups have different average levels of the exposure. So in some way, we've stratified based on the exposure, but in a way such that the genetic variant, which is analogous to randomization in Mendelian randomization, this randomization is not associated with which stratum you look at. The distribution of this so-called randomized factor is the same in each of these groups. And so we can treat each of these groups as if they are like a separate trial and come up with our estimates in each of these groups. Now, obviously in practice, we're not going to have exactly 10 individuals with Z equals 1 and exactly 10 with Z equals 2. So in practice, things will look slightly different. In practice, these values here will differ, but hopefully, if they don't differ by too much, then again, we'll come up with a few individuals we'll come up with a similar distribution of the genetic score between the eventual groups that we look at. And so in each of these groups, we end up, as I said, performing the same overall analysis that we did, but we're doing them in groups with different average levels of the exposure. There was some nodding there. I don't know if that was clear enough. It is quite involved, and certainly I didn't understand this the first time when my PhD student proposed this to me, and yeah. But I think that the key is we want to make sure that we're not breaking randomization. That whenever we stratify on a post-randomization covariate, the problem is that we break randomization. So we want to stratify in such a way that our eventual strata respect randomization, but have different average levels of the exposure. And that we're able to do under the assumption that whatever percentile of the population the individual was for one value of the genetic score, that they're in the same percentile for any other different value of the genetic score.
And this would be X, the genetic score. And I hope that
the score, no, the genetic score is the Z.
The
X is the exposure.
Sorry. And X would be in your study with regard to vitamin D?
Yeah, so X would be the vitamin D.
All right.
Z would be the genetic score.
All right.
I'm sure there
Thank
is
you.
something like because obviously for someone not into that topic, I'm sure there's something like a positive control to that doubly rich thing. So like something we really know in cardiology is there's similar comparisons with LDL cholesterol, because I would be a little afraid that you lose some of your positive results. Obviously you did here, and you say this is the more correct version, which we will have to believe you, and I do believe you, of course, but how do you make sure that you don't kind of flatten too much and lose possible positive results?
Yeah, that's a good question. So we can still, so the same comparison which we looked at initially for the population as a whole, where we said how strongly associated is this genetic score with 25 OHD, hopefully very strong, with BMI and so on, hopefully not so strong. We're able to look at that comparison within each of the strata. We lose something in terms of statistical power just because beforehand we had our whole population, and now we're looking at fifths of the population or tenths of the population, and so on. We have done this for LDL cholesterol, and certainly for coronary heart disease, we get a consistent positive effect within each of the strata, with no sign of any sort of threshold at which lowering LDL cholesterol is not beneficial. Lowering LDL cholesterol is beneficial across the whole distribution that we looked at. Obviously, we can only look at the distribution of cholesterol levels that people have. We're not able to look at the very far extreme as to people who are beyond the normal range of cholesterol levels.
Well, thank you. Well, if that's what that's a huge analysis. I mean, it's highly published. Obviously, if you look into the future now of vitamin D in particular, is that end of story in your eyes? Is that really the nail to the coffin after the neutral vital study? Would you say, from your pure scientific statistical view, you see a zero below everything and say, okay, there is no effect? Is that basically what you could distill from your data?
Yeah, so I mean, I'm a statistician, so I want to be careful about not going beyond my level of expertise. But yeah, I think we're able to look at the population as a whole. We're able to look at reasonably small strata of the population. I mean, obviously, we're not able to look at the very, very low levels of vitamin D and make any sort of claim in that sort of realm. But certainly it seems like, particularly for coronary heart disease, for stroke, that there's no benefit of supplementation for the population as a whole. And yeah, any benefit for any subgroup of the population, again, we don't see anything within the statistical bounds of certainty which we're able to look at. So it's unfortunate, obviously, because if vitamin D were such a cure-all, then we would love to be able to recommend it. But there's no clear evidence for that. I guess the where we haven't looked is in non-European populations or at the very extreme deficient end of the spectrum.
But you also did not find any harm as far as you looked so far. So I'm really a little bit now, surprised by this multiple sclerosis data, by the depression data. So if patients come to us, or colleagues of us who say, well, I have my 1,000 or whatsoever units of vitamin D, at least in winter time, between October and Easter holiday or so, then there's no reason from your part, from the statistician's part, to say, well, this is risky, I guess.
Yeah, so again, I wouldn't want to give medical advice as a non-medic, but certainly from the epidemiological analyses, we don't see any evidence of harm at any level. And we do see protective effects on average for the multiple sclerosis, for some of these other, psoriasis was the other one, which we saw a potential protective effect on in terms of autoimmune disease. And then for depression, as I said, a lot of uncertainty still in these nonlinear analyses, but at least there is some level of a signal there for a beneficial effect of vitamin D on depression in the low vitamin D quantile.
Okay, well, maybe the story isn't finally at the end, and it gives room for more research. Thank you so much for this very insightful discussion. I think we learned a lot. I hope a lot of others will also learn a lot from your talk. Dr. Burgess, great to have you here. And thank you so much for your work. And well, we hope we'll see more of that in the future. Thank you.
Thank you so much for inviting me. It's been a great pleasure.